Good evening, everybody. It's a couple minutes past 7 p.m. Eastern Standard Time. Welcome to this webinar. First of all, I would like to welcome our 4 panelists. I have them on my screen. Maybe you can introduce yourself very quickly. John, let's start with you.
Hey, John Cole from Atlanta and Manhattan, and I focus predominantly on hair restoration surgery. I do a fair amount of lipoaspiration for stem cells, a lot of PRP, a lot of PRF, a lot of pretty much any regenerative protocol you might be able to consider.
Thank you. Lisa.
Hi, Lisa Vuich, Derry, New Hampshire. I'm the owner of RenewMediSpa. We focus on facial and body aesthetics, and also we do quite a large business of sexual wellness procedures for men and women using primarily the M-Site PRP.
Thank you. Rowan, you're next.
Hi, Rowan Paul. I'm in San Francisco and Palo Alto. I am a primary care sports medicine physician, been in regenerative medicine since 2008, and do a lot of PRP, BMAX, history of adipose and whatnot. So happy to be here. Thanks for inviting.
Thank you. Last but not least, Sean O'Connell. Sean, you're muted.
Oops.
There, unmute. Hi, I'm Sean O'Connell, Princeton, New Jersey, and I've been doing research work in regenerative medicine for a number of years. With respect to tonight, I've done a fair amount of work in PRP and PRFM, both the gummy worm and the membrane. My daytime job is cancer immunology.
Perfect. Thank you so much. Again, welcome everybody to this webinar. The reasons for this webinar is that both at Coast Biologics, where we do a lot of courses, where I teach different other courses like specialty med training, or give lectures like, and even these more popular conferences, the question on PRP and PRF pops up almost on a daily basis and during the conference. So we felt together with the panelists that we should, clarify some of the definitions, some of the limits of the products, and where we believe, the use of biologics should head to, and try to stay away from, severe marketing attempts in putting products in a different light as what they are. And actually, we would like to avoid doing harm to any of these products, whether it's PRP or PRF. Welcome. Maybe one of the panelists, you can mute yourself. That would help a lot, I guess. So please mute yourself. Thank you. We are very lucky on this webinar. We have more than 20 different countries represented, so that's a big deal for us. I'm Peter Everts. I'm your host for tonight. On the slide, you see my disclosures. And the panelists already introduced themselves very nicely. Why I feel comfortable talking about this subject, because I've been around in this field for a couple of years. Originally in Europe, doing a lot from the surgery perspective, which we nowadays call biosurgery activities. I was lucky enough to do my PhD on the subject in 2007 at the beautiful University of Utrecht. And ever since, I continue to publish work with physicians, maybe like yourself, and start to support a lot of research projects since I started with M-Site and Coast Biologics. So the agenda for tonight, it's a tough one, I already can tell you. We have quite some things to discuss, and maybe we look for some of the edges on the topic, but we feel that we need to bring some clarity and some clear information. So I'm not going to go over the agenda right now, but you will see the headings of the agenda as we move along. And I think the first thing to do is, well, try to get some kind of a definition in place, right, for platelet-rich plasma, PRP, and platelet-rich fibrin, PRF. And most of you might not remember, but in 2001, a couple of years ago, Joseph Choucroun out of Paris, he was actually the first one to describe platelet-rich fibrin, and he called it second generation PRP technology. And actually the principle PRP or PRF is basically the same, because both technologies use the same blood that we have in patients. But based on, well, the structure of the product, the centrifuges, and even the philosophy of the companies, we end up with different end products. So let's have a little bit of a closer look at platelet-rich fibrin. David Doan, ARFest, a good friend, we did quite some research, was soon after Joseph Choucroun ready to well, to publish and give a clear description on, well, PRF. And in my mind, and I'm pretty sure, well, a lot of the panelists as well, PRF is what it says, a platelet-rich fibrin, a matrix, as you can see it on the right lower end of your screen, and in the middle here in the test tube, because most of these products are test tube based as a device to create PRF. That's where you see a clot occur, and this is when the clot gets out of the test tube. We go over that more in detail. One of the typical features for PRF products or PRF-like products that are cited, well, quite often is the sustained release mechanism. So any of the blood components, whether it's in a low concentration or high concentration of cells, they are embedded in plasma, right? In a non-activated state, it's fibrinogen. When it becomes activated, it becomes fibrin. And as you know, fibrin clots hold a certain volume of cells together. It has been nicely demonstrated by the group of Yazawa with a great electron microscopic studies. And a couple of these typical features for sustained release mechanism is that they provide a biological matrix, right? They create a matrix where a host, where other tissues can grow into, where there is a release for over a lengthy period of days, as long as there is fibrinolysis occurring. So any clot in the human body will lyse up until the entire clot is gone. And actually that mechanism of fibrinolysis is with the release of all the, well, whole blood content, platelets, cytokines, lysosomes, ultimately are being released to their environment. Kawazi did a really great job as well in really making very clear as how these mechanisms really work. So to summarize, PRF made of a unit of whole blood. Test tubes are the main processing devices, so to speak. Typical product will get out of it, which is different than when we try to look for a definition in PRP, right? So in the same period, like Joseph Choucroun, Bob Marks published, well, I would say this landmark paper, and they were somehow competing with each other, because both Bob Marks was in maxillofacial and dental pathologies, and Joseph Choucroun as well. And he published straight ahead on PRP, and he came already more than 20 years ago with a definition that PRP should have a concentration of more than 1 million platelets per microliter. And he used that for a pretty long time. And when you try to figure out all these different products that are on the market on definitions, then again, this paper 2 years ago published from Fadado and his group, and they also indicated 20 years later from Marks, well, that magic number of 1 million platelets per microliter is still sustainable. And so did we in a previous paper with some key opinion leaders who have quite some experience. And then as a couple of years ago, when we already start to have these battles, right, on what is PRP and what is PRF and what are all these different versions of PRF, what does it really mean from a outcome perspective after processing? And the group of Medina here published a very nice, very comprehensive paper looking at 4 different, what we call blood-derived products, including PRP. And they looked at the differences in preparation from a time perspective, from the G-forces during centrifugation, and well, how many platelets can we recover? And they were actually, well, the very first to come up with, hey, we do recognize there are differences. And when these differences were revealed, then when we go back a little bit more in time from that moment onwards, we all have to apologize for failing to have a system in place that really is capable of classifying our PRP products. Up until now, we still have no standard in place. We failed. There were, well, plenty of attempts made in order to, well, to get some kind of a standardization in place, including to the level of the American Association for Blood Banks, but it always failed. And this failing classification system, the failure of standardization, is really biting us now tremendously, because all of a sudden we see a lot of different things happening. Although we started already in 2008, listen, everybody, we can work with PRP products, PRP-like products, but the minute we start to activate them, we are discussing a completely different product. And that's something we still tend to forget in 2022. And when you then look at the proposals as well, how can we make some kind of a classification system, and we don't go into the companies behind the method of production, then the most of the consensus in the early days was still towards, well, pure products before activation. And after we have been rebuttaling about, well, definitions of activations and changes in products before activation, well, we found some consensus, and we were able to bring, not all of them, but quite some interesting commercial products to the table and have them classified and have the proper termination in place. And that was actually the starting point for a bunch of researchers. And when you now look at the initial PRF indications, then you will find the literature go back where there was a lot of attention in dentistry, periodontology, and implantology. And shortly thereafter, and I'm glad we have Dr. O'Connell with us, he was actually one of the initiators with the group to start to work on the platelet-rich fibrin matrices to cover wounds. And from that moment onwards, when there was, well, an initial interest in, in wound care, we saw more different areas out of, well, let's say periodontology aspects to surface, where a lot of researchers believe that there was a proper indication for PRF or PRF-like products. And then the last couple of years, there was a significant shift towards another focus. So leaving periodontology, connective tissue repair, now we see a lot of surfacing activities surrounding PRF-like products in aesthetics, even bone-related surgeries, and also starting in as a biosurgical tool, MSK and spinal disorders, where as we really look on, well, how it all got started on the PRF. And keep in mind, this picture you see on the left-hand side, that's a platelet-rich fibrin matrix. And that's actually one of the starting points on, well, the proper definition and the proper use of a activated, well, whole blood derivative for use. But where are we right now? I think we all together are significantly lost. We lost each other in understanding on what are we doing from a research perspective. We have major journals making one mistake after the other, not really investigating what kind of product has been used, what are the potential consequences of specific product and specific pathologies. And pretty firm, and I'll illustrate those in a minute, claims have been made on failing biological products. And then, well, we should not even discuss now, but I think we can, well, find at least 10 different delivery routes for PRP. And then it even got more complicated the last couple of years, because when initially it was pretty clear on the definition of PRF, the last 2 to 3 years, we find more and different reported formulations for PRF. And that really started to create a lot of confusion. You see the list here, all of these different nomenclatures that have been introduced. Well, the basis never changed, right? We take a unit of blood and we have the goal to process it in order to, well, to create a blood derivative, which we can call PRP, platelet-rich fibrin, activated, non-activated. But all of a sudden, we have different formulations of PRF with different centrifuge settings, with different spin times. And that is where actually claims started to come. And that's going to create more confusion than anything else. And going back to why we failed on the classification, and you see just a list here of, well, I lost counting, but I think at the moment we have something like 40 different PRP or PRP-like devices on the market. We still are battling with too many parameters, right? So this is just a list that we published not too long ago on, well, if we would like to go into classification, what are the parameters? What are the differentials? And what options do we have within each of these differentials? So if you ask me the question, will we ever get to the level where we have sufficient qualification, standardization in place, then I'm afraid it's not going to happen. And I even don't want to discuss right now the differences between a single spin device or a double spin device, because that's going to create even more confusion. So let's try to get some decency in PRP definitions here. So I would like to start this webinar with plasma-based PRP systems that can be defined as a low volume and low platelet concentration systems with some, well, some varieties on the menu. Based on how they're going to be used, and this is just a representation of some of these systems. And then the second biggest category would even be buffet coat PRP system. They use higher volumes, but they're also capable, obviously, for clear reasons, to produce higher platelet concentrations. And they are designed to isolate the platelet-poor plasma layer, a buffet coat layer with certain cells in it or not in it, and the red blood cell pack. So if we can keep this momentum right now, that from all of these different PRP products on the markets, we can make a difference between low volume, low platelet plasma-based systems, including a variety of PRF, so-called PRF systems and PRP systems, then we have a great starting point. Now, where are we with regard to the comparison? So any liquid PRF specimen is just some kind of PRP, right? I hope we can agree to that. I mean, the basis would be still the same unit of blood from the same patient. Then we got some menu options, right, with both systems. Low platelet, no white blood cells, low platelet, full load of white blood cells, and particular white blood cells or a full buffet coat. And then the other component, which is exactly the same for both systems, would be the presence of plasma proteins, right, including fibrinogen. That's exactly where we are, and this is what we can, what we have. And when we start to suplete the calcium that might be, well, out because of the anticoagulant, it might be in because we don't use anticoagulant, in particular for the PRF systems, and we wait for a little bit and we add the calcium suppletion to the PRP kind of products, then we are already square, right? Because we compensated for the loss of the calcium. And why is the calcium important? Because calcium plays a key role in our clotting system. So when we isolate calcium, when we deplete and replete calcium, we have an effect directly on the clotting system. In other words, by adding calcium back into a PRP product, we're going to convert prothrombin to thrombin as a plasma protein, and ultimately we get to, well, the level of fibrinogen, And ultimately, what we would like to have is cross-linked fibrin fibers, right? And those cross-linked fibrin fibers, they create what we call that activated PRF, or even on the right-hand side, you see in a glass dish, you see just clotted PRP, because we were able to activate the PRP by resuppleting the calcium and wait for a while. And if we forget about thrombin or adding thrombin to it, then we just need to have another activator, right? And that other activator is glass. Glass is a very potent activator for platelets, and glass by itself, and that's why a lot of these, well, plasma-based tubes are glass tubes, because they add to the fact that they can jumpstart the intrinsic clotting cascade. And that's why we use in that Petri dish glass as well. So if we do it and we're going to inject PRF, right, then what most people do not recognize is we create something very special. Because if we supplete our calcium to either any of the plasma-based PRF products or to PRP as a standard, in combination with tissue factor, every platelet, every, well, plasma protein will become activated under normal circumstances. Tons of papers have been published about, well, the role of tissue factor in developing clots. We know where to find tissue factor, and again, it's a protein that's present in a lot of, well, in a lot of cells, right? And it's a very essential protein in the entire clotting cascade. And what we just learned over the last couple of years, well, monocytes and macrophages express tissue factor. So in any of these products where we work with particular cells, we, well, would be able to generate, well, the tissue factor. And when you look again at the, well, clotting cascade, that the combination of tissue factor with factor 7A ultimately will give us thrombin, and the thrombin will be able to, well, make these gel clots, right? So when you inject in a tissue, it's a matter of time that any of these liquid PRP products, even liquid PRF products, they will become a jelly mass. They will become activated, and they will keep platelets in place, and they might even, well, adhere to, well, specific tissue types, right? So that is something else. And then we learned recently as well, not recently, but we never discussed it, is, well, how tissue factor can be released from platelets, from human platelets. So we have a reservoir of activators as well. So when we supplete the calcium, we wait, right? We are able to produce in situ activated PRP, either through direct mechanism with calcium and thrombin, or to tissue factor, but we will be able to set up a clot after we do it, and we will have that fibrin matrix that we can create outside of the body in the test tube, or even in a Petri dish, right? As you can see it here. I mean, this is a typical example of a activated platelet-rich gel. So we just can introduce another name to it. Now, one of my less favorite subject is, well, what's happening with all the information here, right? Do we still have this same information? And I'm at the level where, well, we stick to a definition of misinformation. And I think it's pretty clear that we can, well, use propaganda as marketing and the false information as no evidence, and to deceive people as promote certain products. That's where we are. That's where we are. That's what we encounter, and what I'm pretty sure a lot of you are on the webinar have, well, experienced the same. And we will have some nice anecdotes at the end during the panel discussion, but you need to protect yourself. That is actually our mission. I'll show you a couple of slides that I was able to capture from listening to a couple of other webinars. That's why the presentation of the graphic is as poor as it is. But these are just some of the claims that are thrown out in webinars at conferences on positioning PRF, on, well, the superiority of PRF over PRP. Low centrifugation, no need for anticoagulants. That's true in a lot of cases, but not in all of them. And then, well, the advantages here, well, you know what, let's go over all of them just to see. And then what really is starting to scare me is when lecturers start to discuss what the future is going to be for PRF products. And we talk rheumatology, cardiology, neurology, psychology. These are areas, well, where we have to do a lot of work, where we have a lot of failures, even with more profound biological products like bone marrow stem cells, adipose stem cells. We need to be very careful, I would say, before we're going to make any of these claims. From another webinar, YouTube video, a bunch of claims being made on the concept of slow centrifugation, the number of platelets you can have. And then the funny thing is, they end up on the right-hand side with the picture, well, discussing actually, well, the release of growth factors referenced by Bob Marks, who is a very profound PRP user, but nobody cares, right? So we're going to use that same picture, whether it's PRF or PRP, but let's try to, well, to get some of these informations in the right ray of lights. So any of you here on the webinar, if you have any information showing that low centrifugation versus harsh centrifugation, there is evidence, please send it because I can find it. And I'll look for it on a monthly basis. So these claims, and I'll get to you why I believe these claims are being made, and with me a couple other persons, is there is no evidence. Then another funny thing happens is, what are the differences of PRP over PRF? They just mention it, right? There are more platelets in PRF than PRP, but there is never done any reference on which predicate PRP devices were used. But the claim is being made, right? And that's the scary part. Well, you easily can look at systematic reviews. You even can look at large cohort studies that really give you all the answers, and just show you a couple of these here that really makes a nice, well, classification on well, on systems and how capable they are. So we're not going to go into it. If you need these papers, we're happy to send them to you. Then another stunning well, comment made is, well, PRF has 0.4 to 2% of mesenchymal stem cells. If you know how many mesenchymal stem cells are in the bone marrow before they are released into the peripheral circulation, then you're going to think again, right? And these papers really make very clear that in peripheral blood, there are hardly any stem cells you can find. So there is a technique for peripheral blood MSC collections, right? But we cannot do it with our centrifuges. We cannot get any MSC in 10 ml of blood. It's simply not possible. When you look at the method, when they do it, these patients who do peripheral blood stem cell donations for their own therapies, they are in the blood bank. They're sitting in such a comfortable chair because they need to be in there for more than 4 hours. That's blood in, blood out, try to catch some of these MSCs. So simply it's not there. You know what, let me show you this paper. It makes it even more clear. A nice study out of here in the US, looking at different sources for MSCs. Peripheral blood, let me enlarge it for you. Peripheral blood, no stem cells measured by STRO1 determination of CD271. No stem cells could be detected. How can anybody make these kind of claims and try to position a PRF product like that way? We are just doing a disgrace to PRF and what it has been in the past. Another one is also comparison studies between PRF and PRP. 2 studies. Well, PRP is not doing a good job, right? And when you read these papers, I only read the title and even the abstract, you see, these guys, they have a point. It's not working. Then you start to look, what's their PRP product going to look like? And what you see in all of these papers is they just use a different test tube. It has a different color. 2 different studies came with the same test tubes as a base to produce PRP. And 2 more studies, and then I'm going to quit about it because they all come up with the same. We have not a single study comparing a Buffycode PRP system with a test tube plasma system on looking at different outcomes. Now it's even going to be more interesting because this study was published not too long ago, looking at, well, again, comparison, PRP versus PRF. PRF has 10 times more platelets than PRP. Nice study published 3 years ago. People call me, how is that possible, Peter? How is that possible there are more platelets in PRF? So did you read the entire paper? No, but I've seen it, I have heard it, right? And you see the same thing here on the left-hand side. They keep on referring with false information that MSCs are present in PRF. In 10 ml of whole blood, you find 0.5 to 2%. And we have up to 10 times the platelets. Let's debunk it. And I can show you tons of these papers. I'm not going to do it. So let's try to debunk the claims made and what it means. So the study you just have seen, 10 ml of leukocyte-rich PRF tubes, and they had a baseline of 220. Hey, out of 10 ml, they were able to get 0.3 to 0.5 ml of concentrated PRF. That was a 20-fold increase. That's great, right? Then we take a 60 ml device and we have only a 6 to 8-fold increase in platelet numbers, right? So now what's going on here? What is it we need to know? Ultimately, what should be of true and only importance to you as providers is, how many platelets do I have? How many platelets can I use in my treatment vial for my patients? So you only can imagine that, well, that unbelievable increase in platelets and using 2 different systems gives you a huge difference in total deliverable platelets. And that's no more than just multiplying any concentration times the volume that you have. And that's the number of platelets that you can use for your patients for whatever you want to do. So the difference here is clearly illustrated, the low volume versus the high volume. Concentration is just some kind of a very simple measure of, well, telling you we did a good job, yes or no. It doesn't mean you are ready to dose. And then, of course, there is that design characteristic. I mean, a test tube from the laboratory is meant to count cells. It's never had the intention to concentrate cells. So the difference between more sophisticated, detailed devices who have a certain philosophy is a completely different one than turning a test tube device in some kind of a platelet magnifier. And then ultimately, when you do the math, and we are not used to make this mathematical calculations, we see a huge difference in platelet dosing. And then the other thing that really struck me with this paper is the 10-fold increase in platelets and leukocytes can be further utilized for tissue regeneration. Wow. First of all, platelet increase of baseline is not a therapeutic value indicator. It doesn't tell us anything. But it also gives us no flexibility in working with bioformulations. We cannot produce different PRP compositions from what we need. And then the last but not least, 0.3, 0.5 ml. What are we going to do with it? What are we going to do with it? So the sales pitch which I encountered a couple of times, is, yeah, we spin a slow spin, as this gives us 10 times more the concentration. And that's why we have more platelets. That's being thrown out. And you know the true reason really is, if you spin it at higher speeds, you will generate clots. So they had to spin it at a slow speed in order not to have clots. So this is where we are right now with, well, the differences in PRP and PRF as how they are presented. And I think that's not fair. That's not fair to US practitioners. That's not fair to patients. So after PRF made a move towards other indications, we have data from real patients that have been treated, right? And this study was more than 10 years ago done. And they came, well, we did not see any improved results, both in function and retear rates. A prospective randomized study, well, you know, the highest standard of studies we can do, no effect on tendon healing vascularity, which is not a surprise, or any functional rating scale. It even might have a negative effect. That was the conclusions of the author. And then we get another study in a rotator tendon cuff, and these are a couple of years later, and they came with the same conclusions: no benefits to patients. And then the meta-analysis, and then in the meta-analysis, they use PRF and plasma-based products, and they were able in more than 15 controlled randomized study to find any evidence of clinical efficacy for these studies. And if we continue and don't only have a focus on PRF, but let's say on the low volume, low platelet systems, then what you see is this study out of the Netherlands, just 2 years old, using autologous conditioned plasma. And when you look at, they do not recommend ACP as another low plasma-based PRP product for neo-AM injections. But now let's have a look. What is it that study patients received here? And they received a dose of 2.26 billion platelets. That is what was given to these patients. Another study that really shook the tree significantly was this ReStore study. When you dive into the study, what kind of PRP that was being used, what are the data available, you're gonna be laughing at me. So this is just one of the comments that have been made. And I would like to have your focus here on 80% capture rate and recommended standards. We don't have recommended standards. 80% capture rate is simply impossible. Then JAMA needs to have a lot of backside information on the study. This information here responds the platelet baseline concentration and the platelet concentration after centrifugation. And when we then look at, well, simple so math is, well, how efficient are these devices? Then it's pretty simple, right? We need to see, well, what's the yield percentage? And then we know from the literature what can be done. And well, for plasma PRP, there's no more than 35%. So when you do then the ultimate, well, calculation from, in this study, 20 mLs of blood, and they brought it down to 5 mLs, right? And they had a capture rate of 35%. That would bring the platelet numbers to 1.4 increase from baseline, and the 35% is according to the literature. That's what's feasible. But now let's see what really happened in the study. So you saw the baseline values, 271. You saw the PRP concentrate values, 327, gives you an increase from baseline from 1 time to 2 times. That would lower the literature calculated capture rate to 30% and 35%. And what's in that documentation? No, platelet recovery rate of the protocol is 80%. 80%. That is what was indicated toward this great study. This study was one of the best I've ever seen, the way it has been set up, in controls, in designs, in follow-up. And that 80% is a number, when you go to the references, that was provided by the manufacturer of the test tubes, because they didn't do themselves. So research, as you they assumed a different quality number, because if you do demand the other way and say, no, the device is 80% capture rate, that would give you a 3.2 increase from baseline, sorry for the math, but it would give you a reasonable amount of cells to work with. And still, the differences are huge. And again, the basis for these assumptions, the basis for the researchers to do the study was based on the fact that the company provided the data to do this study. And I think that's, well, that's simply a bloody shame. So we have too many choices, right? But the main thing for you to, the main thing for you to consider is do your own solid research. Do not trust only the marketing talk, the social media events, because it's going to be very important for you, first of all, to get your objectives straightened. And the objectives can be summarized as, my goal is pain management. My goal is tissue repair, tissue regeneration. I want to affect the immune local situation of my microenvironment, right? And then you need to make a choice for these different PRP devices. So you need to merge your objectives of the therapy with a bunch of different devices, but ultimately what we're all looking for, and it's in development, is the recipe book. We still do not have a recipe book that really is going to give us all the answers that we need. We're almost there. Look what we have, pain management. We were the first to publish about pain effects and PRP, and we saw there was a dose response curve about it. 2 years ago, this paper came out. Now there is a direct correlation between the number of platelets and the effect of pain killing by intradiscal patients. A good friend, Damien Kupfler, done a ton of work in chronic wound care, in neuron regeneration. He published quite a bit on PRP. Systematic review, a systematic review on the use of PRP and its pain effects in orthopedic surgery. You know what? The higher the platelet numbers, the better the response is. So that's already hinting towards some kind of a profile for pain management. This paper, very recently published by the group of Greg Lutz, they did a great study. They looked at the historical controls, they looked at their recent change in policies, and they came up with more than 10 times the baseline, gave them excellent pain-killing effects for intradiscal injections. Well-organized study with a high significant value, looking at different forms of the pain score, between 5 times baseline and more than 10 times the baseline. So they came up with some kind of dosing. The study where also one of our panelists, Dr. Cole, participated in, looking at alopecia and PRP. And it was the recommendation of the panel that you see above. Well, the recovery rate, how many platelets we need, we have a clear thought at that moment that should be close to 1.5 million platelets per microliter. And we came to the same conclusion in an aesthetic study as well. So the numbers really start to add up here. Tissue repair, functional repair. What we need is angiogenesis, right? We need blood vessels to develop. A nice lab study being done showing the need for at least 1.5 million platelets. Women then look further in changing the local environment, immune modulation, same thing. And then this study came out, actually. It was one of the first studies ever published indicating a dosing perspective. Single dose of PRP, year follow-up on pain and function and inflammatory parameters, and that 10 million dose really killed it completely. Some physicians like to work with PRP to enhance the effect of stem cells. Clear data indicate at least 4 to 8 times the baseline. So whatever we're going to do, we're going to look at platelets, but we should not underestimate the powers of all the white blood cells, right? So apart from platelets, we need to figure out exactly what is it we're going to treat. And if I have a specific tissue type to want to treat, maybe you want to consider adding 1 or 2 different leukocytic cells to it, or maybe the full body clone, because all of these cells in the human body have a clear function, and we need to understand and establish what these functions are going to be if we're going to do it. But first of all, we need to manage what I call the inconsistent triad. We need, as a scientific community, as practitioners, to understand what is these device variables, what are the patient variables, and how does my office staff and I interfere with a proper formulation. I don't want you to read it because we will discuss this in the next webinar, because that's pretty interesting if we all understand it. But the main thing here is a PRP device has great capabilities in really segmenting the different cells. And actually, what should be top of mind if we want to do advanced biological therapies is that PRP devices should be able to undergo a process, what we call gravitational cellular density separation. You should be able to have these different cells nicely organized and captured. And that's where, well, actually the basis really is to get to proper PRP dosing, because in that Buffy-coat layer, how are we going to work with it? That's where all these cells are. It's no magic. It's just following nature. It's just following technology, right? So these cells are always there. They can be in a different concentration, and it's up to you. What do you want to get? You want to have only pure platelets, no RBCs, no other white blood cells, because ultimately then I'm pretty sure that we will get to the level where we are capable to affect local microenvironments and get to the level where PRP really can mimic nature's regenerative repair potential, whether it's angiogenesis, collagen synthesis, restoration of tissues, because this should be your goal. The goal from all of these companies, all of these PRP products should be towards this only objective, that we use, that we're capable of, well, repair and regeneration and restoration of function based on, well, biology that we can do. So when we look then at, the differences between PRP-based and PRF-based, as long as we are at a level where we resuspend our calcium and we have equal product, we compare apples to apples, and we're going to look at different parameters, whether it's the dose, the presence of certain white blood cells, the presence of, well, plasma proteins, and can convert them from fibrinogen to fibrin, and what these individual components are going to do on angiogenesis and fibroblasts, then there are differences. And it doesn't mean that one product is superior over the other, but I want you to take away that we are in need for the development of new thinking. We need to think about different platforms. Different PRP products will have a home base to work with, right? And if we stick to the limits of our products, with PRF, we had a good starter, we had great results in implantology, in periodontology, in wound care, which is a completely different environment. It's a different surgical arena than when we start to modulate intra-articular osteoarthritis, or when we repair tear tendons. That's a different arena with different tissue types. So some takeaway messages, and before I open up the discussion and start to discuss the panel, do your own research. Do not trust social media marketing and sales promotions, right? Ask for peer review data. Do not accept PowerPoint slides that give certain presentation. We already concluded there are too many PRP devices on the market. But the sad news is it's out-of-pocket money, right? And different PRP products have different characteristics, but also have bad or poor results. And guess who's paying for that, and who should not be paying for inferior product, right? So the fibrin matrix is a very powerful tool from the beginning with PRF products. I like it a lot. I experience it myself. I understand the mechanisms of polymerization or fibrinolysis and the more sustained use of growth factor. That's a very powerful tool in well to have, but and you can have access to it. You just need to understand how to get it, how to make it, and what the function of that matrix is going to be. Single spin, double spin, we didn't discuss it, but there are differences, as you can imagine. And then please start to think about platelet dosing. So we need to get away from X times the baseline because it really means nothing. So if you want to inject 5 mLs and it has 4 times the baseline and the baseline was 150,000, you are still underdosing. So validation is going to be important. We have seen in the literature that angiogenesis, collagen synthesis, and immune modulation, they really depend on proper platelet dosing and formulations, right? And already clear evidence that pain management is controlled by platelet numbers that we can create. We need to come up again with proper definitions and characterization. That's going to be a tough job, that I'm going to tell you that. But at least we should be able, as a community, as practitioners, as scientists, to create clear definitions for platforms, right? So when is what kind of PRP best indicated in what kind of fields? What are the indications for specific PRP therapies? Last but not least, we're going to have more of these discussions at our upcoming Coast Biologics conference. Go to the website if you're interested. We have a lot of hands-on workshops. And at this moment, I need a drink. I got a glass of water next to me here. I would like to ask the panelists to, well, unmute yourself. And I want to get started with some questions. And in the same time, I will already have a bunch of chats getting in on questions from you as an audience. So please unmute yourself, Lisa, Rowan, Sean, and John.
Unmuted.
Unmuted, loud and clear. Thank you for that.
Ready.
I'll give you one that I ran across, Peter, that the group might get a kick out of. There is a new product out that doesn't use a conventional PRP system, but says it gives you a PRF. And if you look at the system, it actually heats plasma to over 90 degrees. To me, I don't see the difference between that and a fried egg. You know, good biologic cover, but literally it's in there. You can find it, and you look at the oven. I thought they had, you know, mixed up Fahrenheit and Celsius. No, 90 degrees C. So I don't know any, even on those thermal vents, I don't know any protein that's going to survive that, but I thought you might find that interesting. Neat product.
I believe Lisa has also discovered a new variant in, well, PRF products with additives. Lisa, go ahead.
Well, I don't know about a new variant. I mean, the biggest challenge in terms of you know, that I face in terms of teaching, you know, as I teach for a specialty med training, teach sexual wellness procedures, the biggest hurdle to come over in terms of having people wrap their head around this is you know, understanding that the patient comes in with a certain platelet count that day, and whatever it is, we can't alter it. And if we're doing a procedure that calls for 7 mLs or 10 mLs of, you know, of good quality PRP, and we define that good quality PRP, you know, as 1.5 million, you know, per microliter, there's a math involved there. You know, you're going to need a certain fairly higher volume blood draw to end up with 7 to 10 mLs of PRP containing that number of platelets. So as you know, I think, Peter, we've been measuring with the Harbor Cell software we've been using. It's got to be 5 years now. We measure patients' baseline platelet count. The software does a calculation for us that tells us, well, based on that platelet count and based on your system, this is how much blood you need to draw, and run it through that system to get the platelet count goal at the end for your procedure. And it very routinely, most of the time, has us drawing between 60 and 90 mLs of blood. You know, so we'll then elect to either use our 60 ml or our 120 ml, you know, pure PRP kit to get to that number. And then again, we use the platelet counter and we test the PRP before we inject it to document the number of platelets we're delivering, what the concentration was. So I just see so many people going through with these test tube systems and they're like, well, but it's, blah, blah, blah times baseline. And I'm like, but you drew 2 10 ml test tubes. How many platelets do you think are really in there? Okay, you need X platelets, X number of platelets, times X number of mLs. That's your procedure, whatever it is, you're injecting a joint or whatever, how many mLs you want or what dose you want. And I think that's the biggest sort of, hurdle to overcome, is to understand that there's a simple, not a simple, but a very straightforward math here, that many times the failure of these procedures, or people coming up with treatment failures, it's because they didn't draw enough blood to begin with to get enough platelets for angiogenesis for their procedure. So I feel like that much, has to be said.
Yeah, I would concur, actually, Lisa. As I've gone through this over the last decade or 12 years or so, my volumes that I'm drawing is steadily going up and up and up, trying to get that capture rate and get that dose as these studies come out. And especially Dr. Himanshu Bansal's study, that's a pretty good dose for one of the first dose studies. 10 billion plates is a lot, that's for knee osteoarthritis. So you're not going to get that in a 10 ml syringe, which is impossible. So, it just doesn't pass the smell test.
Regardless of how efficient your system is, you can't,
Right.
you can't make platelets, poof.
Yeah.
I hate to say it, it's GIGO. It's GIGO. You got to think, what are you starting with? And then what's ending up in your prep? And if the numbers don't come out, there's clearly a threshold. Depends on what your application is. If it's angiogenesis, vasculogenesis, if it's osteocyte recruitment, if it's fibroblast recruitment, there's a threshold. And if you don't hit that threshold, you're just not going to get an effect, especially in those indications where your attendant blood supply is awful. Like Peter showed all those early studies with rotator cuff. Pretty harsh environment, not a lot of blood there. And if you don't have the biologic oomph, you're not going to get it.
John, we have a question coming in. Do you have any experience on using proteins with hair restoration and PRP?
What kind of proteins?
You're talking about the PEP factor?
Yeah, PEP factor, yes.
Well, there's a little bit of research that I personally have not participated in yet, but it's predominantly using micropeptides, really, nanopeptides that actually have the ability to diffuse across the skin. I actually have some of those. As far as the PEP factor, I believe it's probably more of a mesotherapy. And I don't know of any study that supports any of this concept. A single peptide, what's it going to do? It's kind of hard to say. It's like a single growth factor. It's not the single growth factor. It's not 1 or 2 growth factors. It's the milieu of cells. It's the milieu of growth factors. If even with lipoaspirate, you're not just isolating one thing. It's everything in that milieu that's important, and then what you add to it. So if you add a single peptide to it, I wouldn't expect much out of that, other than another marketing tool for somebody who thinks that PRF is going to be equal to PRP. It's not. There's no way. There's no way you can get the same volume growth factors to inject in any part of the body. It's probably a great adjunct to good quality PRP. It's a great product for grafting, as it was used in maxillofacial surgery. It's a great product for treating wounds, but it doesn't really have a clinical aspect in cosmetic surgery or in hair restoration surgery or in orthopedic surgery, in my opinion.
You have been using PRF as well. You still use it, John, right?
Well, I think one of the advantages of the PRF is it is a fibrin mesh. And there are a couple of ways to prepare it. I use filters like from Adenizer and Microlyzer to break this down. And then I can add that into good quality PRP and inject it. You just have to be careful not to get into a vessel and cause an occlusion. There are other ways to play with it. For example, you could add an anticoagulant, pull off the top layer, concentrate some of the platelets down below, like you might even with Regen, and then add calcium to it, and add that to your high volume number of platelets, and inject that. And as you know, I sonicate my platelets, so I never worry about adding any non-steroidals because I've already activated, not activated, but burst my platelets. I've got 5 times the concentration of high molecular weight proteins in my final sonicated product. Because I do believe that a lot of the high molecular weight proteins like PDGF and VEGF get trapped in the fibrin clot. So it's kind of nice to get it out there and really slam the tissue.
Good. Thank you, Rowan. We discussed low volume, low platelets, high volume, high platelets. Where do you see in sports medicine a differentiation occurring between, well, let's say these two categories of PRP products?
Yeah, I mean, I think if our goal is, I mean, clearly there's been a dose response curve for pain, and a lot of my patients, certainly in the sports medicine world and sort of musculoskeletal world, they're coming in with joint pain, they're coming in with tendon pain, and so, you know, it's going to be a little hard if you're following the evidence to use small volume, you know, low yield products to help with their pain. So I think it's starting from that. And then I think from a healing point of view and a neovascularization point of view, you need a certain dose to achieve that angiogenesis. And again, it's going to be hard with a low volume product to achieve that concentration above 1.5, right? So for me, it's becoming less and less of a use case for those low volume 10 ml systems. You know, I just don't feel like I'm getting enough of a dose. I don't know. You know, I don't have an easy use case for my world, for tendons, for ligaments, for cartilage, for joints, for arthritis. I just don't feel like I'm getting that right dose. So
Thank you.
maybe you can educate me if you think there are some things. I mean, could maybe in the neural world, you know, could there be a use for like a hydrodissection?
Well, I'll tell you from personal experience, for neuron regeneration, we need the numbers up to 1.5 million per microliter. These are very high numbers, but then you can make a difference. There are nice studies published in diabetic patients with chronic neuropathies, where specific methods really affect the pain killing in these patients. Lisa, how important in your practice is neoangiogenesis for what you do, both from a facial aesthetic and sexual wellness perspective?
Well, I think from a sexual wellness perspective, it's critical, because since we started measuring and doing, you know, higher volume, you know, draws, we don't really get treatment failures, you know. Many years ago, when we were using lower volume and lesser prep kits, I mean, it was, it would seem like sometimes a roll of the dice. Who's going to respond? Who's going to be satisfied with their treatment? Who's not going to be satisfied with their treatment? And now we don't sweat it, so that, that right there is, gold, to know that you're gonna, 9 point something times out of 10. I mean, there's always going to be somebody who needs an extra procedure or combination therapy or something. I think with respect to facial aesthetics, it's always kind of harder to say, sometimes we're just need a little oomph in one little area and we just need an ml, of something decent. That's a whole different ballpark than I need 7 to 10 mLs to do my procedure. So that just, so if we're just putting something in a tear trough, maybe we can get away with, a test tube system and, and have most patients have a reasonable result. But, our our medical based, interventions, we definitely need, the angiogenesis for sure.
Yeah, I think in the orthopedic musculoskeletal world, we definitely, we're in toxic microenvironments, right? And we're trying to really change those microenvironments. And it's going to be really hard to do that with small volumes and even if you have an ultra concentrated PRP and you only have 1 ml, you're trying to change the microenvironment of an entire knee joint. Is that really going to work? Yeah, probably not, right? You really need to flood it, cover the synovium with a significant amount of volume, right? So there's some practical needs for higher volume stuff too, right? So,
Sean, are you aware of any study that's compared in facial aesthetics and hair restoration, the difference between a PRF or plasma-based product?
No, I wish I was. I think there is more literature out there to this question in oral max, some in ortho and in wound care. In aesthetics and in hair restoration, frankly, I think we're just scratching the surface about what the critical parameters are. I was listening to Dr. Cole. Out ex-US studies, we were basically using PRP as a vehicle to use stem cells for our hair restoration procedures. And it worked very well because the PRP would support our stem cell preps, which we were using to inject it. Obviously, this is not a US application yet, but the idea was that we were giving enough. I did have a question on hair restoration to John. Did you ever use exosomes with PRP to give a real dose of proteins?
Well, every cell makes an exosome, right? And I started
it's a mass effect, depending on what you're talking about.
Yeah. So I started out looking at the bone marrow derived exosome, and I really didn't see any advantage to the bone marrow derived exosome.
Didn't buy anything.
I did see a really good paper presented in last September on amniotic cell derived exosomes, amniotic membrane. And it was an impressive paper, but until I see it and confirm it, I'm a little skeptical.
It's another anecdote.
The exosomes is sort of like a car with gas in it, ready to go on a long journey, but it doesn't know how to get there. It doesn't have a driver. It's not started yet, and we got to figure out how to really initiate it and get it moving. But adding something that's ready to go to PRP, I don't see how that's going to work. Now, certainly, when we add PRP to mesenchymal stem cells and that sort of thing, even to there's new ways to make mechanically disaggregated mesenchymal derived stem cells, and you can add PPP and PRP to that. But I would certainly say go PRP.
Yeah.
Good quality, and it's dose dependent. You're not covering a scalp with a 60 cc draw, even of M-site. You really need to be at 120. And it's probably going to give you a little more than you need in many of the cases, but you're not covering a scalp with the dose patients need with a single 60 cc draw. You need
that's for a whole scalp. What kind of area are you talking about?
We're talking about front to back. We're talking about 180 to 250 square centimeters.
Yep. No, you're absolutely right. Maybe not even 120 is enough.
Yeah.
Yeah. Well, it could be, depending on what the baseline is. Right. So,
your baseline's high. Yeah.
Yeah. See, I think one of the problems is most of the patients, most of the doctors don't really understand the kits, and they don't understand for sure how to manipulate the kits or how to maximize what they're getting out of the kits. And because of that, they don't understand that something like Regen is a dog with a whole bunch of fleas. It's not a good PRP option. You shouldn't even consider it. It's not going to have an influence on hair growth, not in any way, shape, form, or fashion, no matter how you manipulate it, and you don't have enough volume with the number of tubes they give you. So, with Angel Arthritis can be a good product, but it's got a very low capture rate, and to run 2 kits on that is cost prohibitive in most practices.
You drive up the hematocrit as the dose goes up with that system.
We have several questions left on the chat. I'm going to read them. I'm going to assign them to one of you, but please be very prompt in your answers. Top here is for hair restoration. I've been doing 3 treatments, waiting to the 3 months in between. What are the data showing is best? I'm injecting 10 to 12 cc, drawing up 60. John, you want to share some of your secrets?
Yeah, and he said he's using MSite, I believe. I would say, you know, 10 to 12 cc's is not going to give you the dose of platelets you need unless he's got a very high baseline, probably thrombocytosis. You're going to need a smaller drawdown, probably around 6 cc's, 5.5 cc's would be what's left. And I would say you need to go to 120 draw.
Thank you. Rowan, I'm currently mixed PRP with adipose concentrate, 3 cc's of PRP and 4 cc's of adipose for large joints. Would these be more stable and stay in place by adding PRF? And would this be difficult to mix with adipose and inject through an 80 gauge needle? Or does the volume injected not matter as much as the concentration injected? Oh, a couple questions.
A lot in there.
Yeah, exactly.
Let's see if we can break it down. So
yeah, so he's mixing PRP with adipose in a 3:4 ratio for large joints.
yeah,
Would it be more stable as a mixture by adding PRF? I think what is really meant is by adding some kind of a, well, agonist that creates a clot instead of PRF.
yeah. I mean, as far as the adipose with PRP, I mean, obviously there's some really nice physiologic evidence that I think makes sense to do that. Now, I will say that, you know, we track all our data and data biologics and highly recommend people track their outcomes somehow so they know how they're doing for many reasons. But I think when we look at that data, it's actually not clear to me that adding PRP to adipose changed my outcomes. So in some cases, especially my older patients, I do add PRP. In my younger patients, I don't. So, and that's a direct change after looking at my own data biologics outcomes data. As far as making it more stable if you add PRF, I mean, I think, yeah, I mean, there's a fibrin, you know, 3-dimensional matrix there that potentially could kind of keep things in place. So I think if there's cartilage defects, it sort of may be helpful to you know, kind of have a PRF, you know, membrane and then infiltrate with high quality PRP or high quality adipose. But I don't do it routinely. I think it's a case by case example. Maybe there's some potential to change the delivery of growth factors over time with PRF. But yeah, I don't think we know yet, bottom line. I think
can you inject through an 80 gauge needle?
You can inject through an 18 gauge needle. I'm able to inject, you know, depending on the system of adipose, even through a 20 gauge needle. So
that will be nano, micro fat. What is the fat constitution?
Yeah, micro fat.
Micro fat. Perfect. Is there any comment on companies making comparisons? Yes, there are. Happy to send you those papers. We discussed the exosomes. What else? PRP and PRF appear to be exactly the same thing, except the one is pre-activated and the one is not. It is not true that as soon as PRP is injected, it's going to become PRF due to the fibrinogen converting to fibrin without adding an activator, since the activator, so why is that? Yeah, because, well, tissue factor is a very profound activator, and it will. So in experiments done in animals, when you inject calcium repleted PRP, the surrounding tissue and the use of the needle will activate the PRP, and it will form in situ a gel clot, and that definitely will happen.
I'd like to make a quick comment on that, Peter.
Absolutely, Sean. Absolutely.
There's a spectrum, if you will, on your matrix. If you go to a chaotic blood clot, you know, it's complex, it's chaotic, and frankly, it's not very stable. It's resolved very quickly. If you talk about Chokran's PRF, you've got reasonable branching with the centrifugation. If you just take PRP and you recalcify it, and you stick it on the bench, it will clot. But I can tell you there's been studies that show that those are linear fibrin fibrils that are very unstable. And we know it'll retract and give up all its fluid within minutes. In contrast, that membrane PR matrix that you showed from the study that I did, we're spinning that at 4,000 times G. So the cross-linking of the fibrin is pretty profound. And that thing can be sutured to tissue. All right, so that's the far extreme. So my only point is that when you say PRF or platelet-rich fibrin matrix, you really need to specify, well, what's the structure of that matrix and what's its stability? I'm very much with Dr. Rowan and the rest of our panels, which I think these are wonderful things to keep your cells and your growth factors at the treatment site. But when you do that, you have to specify what is the nature of the matrix we're making.
Yeah, but you also have to get them in. And
yeah.
that stuff can be hard to inject.
Yeah.
And you put that in a
That's why I hang around the operating room too often, Dr.
I'm
Cole.
telling you, you put that in the supratrochlear artery, you're going.
You can't. Yeah, it's hard.
Unilateral blindness.
You have about 10 minutes, and then you're done. That's about it. Once you make it, it's going to clot, and you're not going to get it through any kind of cannula per se.
Timing is really important.
Very critical. No question about it.
You got to move fast and prep your MAs and get them ready to go. Because you miss your window, then you got to start all over.
It's there in your syringe dead. You got to pull another kit out.
Lisa, I got a question for you. Are you recommending most practices to be testing every patient's baseline, or would you still say that a 30 ml kit is typically sufficient? Should we be recommending all patients just to use a 120 kit, for example, in sexual health?
Well, testing does add cost, which can be, significant. It can be a few $100s, added to your cost to perform the procedure. So, and sometimes that can, really be sort of hard to wrap in, based on what patients are willing to pay. So it's not free. And so, what I try to, tell people we train is like, listen, the vast majority of the time we're doing 120 ml kit, because we needed at least 90 mLs, so if you, and certainly not less than a 60 ml kit. So, I think, if you're not going to test, you should at least be in that range, and using a high quality, capture system, double spin, et cetera, to get you there. And, you're going to, and the difference between a 60 ml kit and a 120 ml kit is not a big deal, in terms of dollars.
Yeah.
Right. And even if we use the 120 ml kit, we're rarely like overshooting. Like we rarely get something that's over 3 million, per microliter. So I don't think you can go wrong doing the higher volume, if you're not testing, but certainly I wouldn't do less than 60 mLs.
Thank you.
Yeah, but for a lot of docs, $15 is too much.
If $15 is too much, wow, like,
yeah, it's not PRP.
Any suggestions from the panel on, how do we move forward in education? What mechanisms do we need to have in place in order to get, proper information, proper training to the forefront? What would you see when you look in your practice, whether it's your MAs, it's your associates, or whatever? How are we going to bring the proper knowledge and evidence to these people?
The challenge, I think a lot of us, we rely very heavily on our MAs. And if they're processing your PRP, and even with the MSite system, like if you process it wrong, you may get a higher hematocrit, you may get a lower capture rate, and it can make or break your product and your patient's outcome. So I think, I'm very really strict with my MAs in terms of like how they process, and they watch me do it a lot before I feel comfortable having them do it. And for better or for worse, it takes longer, but I think it's it's like a mini residency for them, right? I think the basic science stuff, I think it comes back to that, and it can be dense and hard to understand sometimes, and but it's so important for understanding, because it's biology we're using here, right? And if we don't understand the biology, that can confuse things and again affect your outcomes. So really going back, I read basic science papers all the time, and I always learn something. So
Lisa,
a lot published by you guys.
Yeah, thank you, Rowan.
Well, we got to standardize how we prepare stuff, and we got to teach people how to use it. We got to let them understand that there's a vast difference between poor quality products with low numbers of cells and high quality products. A lot of these guys don't think regenerative medicine works, but they've never used anything of value. So that's part of the learning process and the education process.
I think dispelling the confirmation bias, right? There's a lot of confirmation bias in both directions. So.
Lisa, any thoughts on education from your end? What are your experiences?
Any thoughts on indications?
No, education.
Oh, yeah. I honestly, sometimes it feels like you're, I don't know, standing in front of a band, and there's all the noise coming at you, and you're just trying to, make your little point, and there's just so much noise coming from all of these companies, and so much, as you said, disinformation and misinformation. It can feel overwhelming to really try to speak against some of it. So I think obviously these webinars are critical and helpful. We're actually doing a clinical study now, because I guess at the end of the day we need to publish, right? I mean, that's
your way. Yeah.
It's the only way to push the tide in the other direction. But we're doing a study using shockwave therapy versus shockwave therapy plus PRP for women for sexual wellness indications, and doing all the testing and documenting the platelet count delivered, and all the surveys and the FSFI and everything, and before and after, and at 3-month intervals, and hopefully, and so far very, very promising results. Most of the women are going for the combo, the PRP plus the shockwave. But I think we have to do that using the right kit, the right amount, and publish the data and say, there you go,
Gotcha.
results.
We are running past time, but we still have a quite significant number of attendees on, but I still would like to use a moment now. Any afterburners? And we start with John and go down to Lisa. John, any afterburners after the webinar? Any advice, any comments you want to make to the audience?
Learn the difference regarding how to prepare the products. And if you use a product like Insight, you can fine tune it to the cell count you need based on the size of the area that you're going to treat and the individual pathological situation. So it's a good
Thank
product.
you. John, sorry, Sean.
I think the only thing I would add here is that I agree with everyone. We have to make sure they understand what a proper prep PRP, PRF is. But on the other hand, we have to make sure that the application is sound. What's the treatment site? What's the method of application? Have you prepped the patient? Have you prepped the site? What's your follow-up? It's great to have a nice lock-loaded gun, but you better make sure that your follow-up is appropriate.
Rowan.
Yeah, I think there's, it's exciting, it's sexy to kind of talk about biologics and PRP and bone marrow and stuff like that. But I think as clinicians, we need to step back and say, it really starts with a good diagnosis, especially in our world and musculoskeletal world. And if you're treating the wrong site with the best PRP ever, best bone marrow ever, you're not going to get your patient better. It starts with a good diagnosis. Then you have to get to the right place. You have to get it to the right place. And so again, in my world, that relies on image guidance. So if you're good at ultrasound guidance, you're probably going to get it to the right place more often. And therefore that might translate into better outcomes. whether you have good quality PRP or not, but probably higher with good quality PRP.
Well said.
And so I think that, start with those two things before you jump into, just hog wild using this stuff. Your patients will be happier for it. You'll have a better reputation at the end of the day. And
Yeah.
that's what will make your practice.
Let me just add to that, Rowan, with hair. If your patient is completely bald, I don't care what you put on that scalp, it's not going to grow hair. It's like trying to grow grass on the sidewalk. It's not going to happen.
I have sidewalks.
Lisa, before I give you the last word, I permit myself one question. It came up a couple times. How do we prepare patients for any PRP procedure? Is there any advice you give to your patients the day before, 2 days before, you give them certain medications? Is there anything that you do pre-treatment to optimize outcomes? Ooh.
Well, are you asking someone specific? I mean, we have people avoid anti-inflammatories, avoid alcohol, try to get some exercise, hydrate themselves very well. Those sorts of preparatory.
What about
requests.
diet restrictions? They can go to the diner and have their greasy hamburger. You want to have them on fish and salad?
The pastrami PRP.
No, seriously,
That's a good question. That's a good point.
Flocculent.
Those of you who have done a bone marrow aspiration, right, and Rowan, look at you, and patients with that greasy bone marrow concentrate, and you ask them what they had the day before, and that big Texas steak gets out there, or that dirty McDonald's burger gets out there, you got your answer. So is anybody paying attention on, except for hydration and avoid certain drugs, any other supplements you would like to give, not give? Any pre-treatment advice?
Well, I actually pull people off statins. I think at least again for kind of stem cell function, regenerative engine function, statins seem to inhibit that.
How soon, Rowan, did you pull them off statins?
It's risk-based. It's definitely risk-based. I mean, if they're just doing it for primary prevention, probably a week before. If they're, and then I keep them off it for at least 3 weeks after. And then if they're high risk, say they've already had some sort of cardiac issue, MI, stroke, something, then I have a conversation with the cardiologist and try and come up with a risk-based strategy on that. But that's a very
This is almost tracking NSAIDs. Pull them off of NSAIDs a week before to several weeks after.
Yeah.
Like if you did a rotator cuff or something similar.
Lisa, anything you do specifically?
No, we haven't.
You look at immune deficiencies? Pre-treatment, you look at hormones, there's, silently taking without letting you know?
No, and we don't have a way to really, measure that. I mean, we just keep track of who's on what. But again, we're not having treatment failures, to speak of, regardless of not trying to control for those factors. So I guess, if we were having treatment failures, we might be pushed to try to figure out why, but seems to be working. So.
Good. Well, it's 8:30. I think we did a great job. I thank you all for being on the webinar as panelists and as experts. Thank you so much for making your time available and share your experience with us. I thank the attendees for signing up for this webinar. We have your contact details. Reach out if in the event you have more questions or more information. Any of the literature reference is available for you to get. Just let us know, and we keep you posted on on next webinars that are going to come up. We certainly have some great ideas also following tonight, and we are happy as Coast Biologics to follow up on those. And thank you all. Have a safe trip home if you're not home, and enjoy your evening. Thanks so much, everybody. Thank you.
Thank you, Peter.
Thanks. Bye, guys. Thanks for organizing.
Bye-bye.
Thank you, everybody. Bye-bye.
Bye.